Good afternoon, everyone. We're going to go ahead and get started as soon as we all get situated. We are in a new place, so we are calibrating. We welcome you for being here. Happy 2023. Here we are. We want to welcome you to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. As you know, the commission typically meets on the fourth Thursday of every month. This month, we are conducting a two-day meeting. On the first day, today, we will be meeting from 2 to 5 p.m., where we consider approval of the commission's full service partnership report, also the approval of several innovation projects, and receive a report on the governor's 2023-2024 proposed budget, the commission's mid-year expenditures, and also consider approving new expenditures. On day 2, tomorrow, we will begin the meeting at 9 a.m. and focus on the commission's 2020 through 2023 strategic plan, and also begin planning for the 2024-2027 strategic plan. We thank you for joining us today and hope you will be able to join us again tomorrow as we plan for the rest of 2023. The commission's strategic plan for 2020 through 2023 is committed to 3 strategic goals and objectives to advance the commission's vision of well-being for all Californians. Cody, could you please put up the strategic goal slide? Thank you. At this time, it is my pleasure to welcome and introduce Dr. Matthew Chang, the Behavioral Health Director of the Riverside University Health System. Dr. Chang became the Director of Behavioral Health in 2018 and served as its medical director from 2016 through 2018. Riverside University Health System Behavioral Health provides clinical and substance abuse services to more than 60,000 people annually in the nation's 10th most populous county. It operates 50 clinic sites across Riverside County, including 3 mental health urgent care centers and 3 transitional ACU centers serving young adults between the ages of 16 and 25. We really appreciate the chance to join you in your beautiful Riverside County. Typically, the commission meets at our home base in Sacramento, but it is important that we have the opportunity to connect with communities across the state, learn what is happening, and engage directly with local community members. Again, it is wonderful to be here, and at this time, I would like to invite you, Dr. Chang, to say a few words about the commission. And I want to go back. I said that about behavioral health, the Riverside University Health System, I use the word substance abuse, and we talk about use. I've been educating our school districts about that. So I want to just clarify that language, please. So I apologize for that. So Dr. Chang, please.
Thank you so much. And I don't know, is there the clicker over here by any chance, sir? I'll just try to move this ahead. Back, sorry. Oh, we'll go back. Sorry. We'll click quickly. While I am clicking, I want to thank you for having me here today. And thank you for joining us in Riverside County and coming to visit our fair county. I want to thank you for inviting me to welcome you all and say hi and say a few things about what we're doing at RUHS Behavioral Health. They asked me to do the welcome for the California Hospital Association, maybe I guess a couple months ago and nearby, and managed to have them not throw anything at me then. So we'll see if we can go 2 for 2 today, hopefully. The first thing I want to say about Riverside University Health System is that it is just that. It is a health system. From our friends at Public Health, who have done amazing things during COVID and hopefully coming out of COVID. The community health centers, we have 14 community health centers spread throughout the county. And then medical center. The medical center really became a regional leader and a state leader during the pandemic. It's a 439 bed facility that actually, because of its leadership role, took up to 527 patients at its peak and continues to see volumes over 500. On top of that, there are 44 hospital-based clinics. And really that just speaks to, I think, the ability of RUHS to mature and evolve and best respond to the needs of the community. But I am the behavioral health person, and this is the behavioral health conversation, so we'll talk behavioral health. What I want to point out here on the slide, this is actually one of our crisis campuses. I think you mentioned the mental health urgent care. So this is one of the mental health urgent cares on the left, and the building sort of in the center off to the right is a crisis residential treatment center. And so these were funded in part by MISA capital funds. And I think in compare and contrast with some typical behavioral health facilities, this actually won a Riverside City Beautification Award back in 2018 and 2019, and a real boon for our community. Speaking of behavioral health, so we have 79 internally run sites. We partner with 140 community-based organizations spread throughout the 7,300 square miles of the county. One of the things that we're proud of is that we are in 100+ school sites through a variety of programs. And actually, that's one of our key areas of expansion moving forward. And we see about 60,000 folks annually over our service array. And we've done that by building out our continuum of care. And I'm not sure how well you can see that on your screen. But you've heard the adage, when all you have is a hammer, everything looks like a nail. This is sort of the antithesis of that, and that we've been building out the continuum of care so we can better match our consumers with right care, right time, right place. You'll see programs such as our CARES line, where people call in and get screened to the right level of care, our PCIT program, our FSP programs. I was interested to hear you guys are doing, I guess, the annual report on FSP programs. That's certainly an area we've redoubled or tripled our efforts. And then moving on to our crisis systems, including the mental health urgent cares and the mobile crisis teams, which I'll talk about. And then moving up to the acute hospital care as well. And then the substance, I got to correct myself here. So substance use disorder prevention treatment. I'm going to be coached better on my language here, but a similar vein in terms of the continuum of care, moving from CARES line where people call in and get screened and triaged to outpatient services, IOT, all the way moving up the continuum of care. And we've actually managed to do that despite our historical funding inequities that we continue to struggle with. From a very high level, Riverside County is actually short $186 million each and every year to provide behavioral health and substance use disorder services across the county. We're actually $800 million behind LA County. We are 56th or 57th per capita, and we get about 55 cents on the dollar when you compare us to places such as San Francisco. So this is my simple brain wave of seeing things. I mentioned that we see about 60,000 folks a year. Based on prevalence rates, we know we need to see additional 100 or 110,000 population. There's a rising need, a rapid growth of Riverside County. We're actually the fastest growing county in the state and the second fastest growing in the country behind only Maricopa. I know, in terms of hospitals, we need a hospital to be replaced. The inpatient facility was built in the late 80s and dedicated in 91. The population has more than doubled since then. It's a 77-bed facility as part of the conversation regarding our partnership with the health system. We actually took over 100 consumers, 100 patients at a time, not enough money, which I talked about, and then not enough beds. There's a best practice recommendation that you have 50 inpatient beds per 100,000 population. Riverside County is 8.33, and actually 0 child inpatient beds. The only child in the defined terms is 0 to 12 years old. Beds are in San Bernardino, the neighboring county. There are not enough housing and not enough placements. So what we've done about it, parts of what we're proud of, we really focused on building out the continuum of care. During the pandemic and up and down the levels of care, we opened over 300 beds. We actually believe that's more than other county behavioral health departments have opened across the state. But the negative part of that is, we're all high-fiving each other, and that's great. And a week or 2 weeks later, all those beds are completely full. And it speaks to, I think, really the unmet need and the continued demand in Riverside County. We have more beds incoming. In several weeks, we should open some beds, but we're under no illusions. We know those beds will be filled up, a couple of weeks after they open. One of our strategies has been going after competitive grants. I don't think I have the data here, but in the last couple of years, we've drawn down over $200 million in competitive grants through some statewide programs, which we're proud of. Crisis teams, which we'll talk about. And I think I'll bring it up, this piece up here is when you talk about crisis teams, urgent cares, full service partnership programs, we talk about a limited resource, you can build more or use less. We need a new hospital, but those are expensive. And so on the use less side, it's sort of how can we build the continuum of care downstream to keep folks out of hospital, out of jail, and off the street, which I'll talk about. And so actually right there. So in two sides of the same coin, I think, is our effort on full service partnerships, behavioral health integration. I don't think I'll go through this today, but this is our work with a network of RUHS community health centers that are spread across the county. We look at CalAIM and CareCourt in the same bucket in the sense that we would like to have a larger seat at the table, a louder voice when it comes to policy determinations, the operational details, as well as the fiscal aspect of those programs. And then I'll just leave you with what we're trying to do to move forward is our focus on recovery villages. I do want to spend just a minute talking about our crisis teams, and cheaply called one team to rule them all. These are our teams that go into the field or schools or with law enforcement and interact with people who are in crisis. I think they're very effective at keeping people out of the hospital. It's estimated that 95% of people who interact with our crisis teams don't require psychiatric admission 60 days post-contact. So our mobile crisis response teams, which are our first teams, these teams actually won a CSAC Innovation Award back in 2018, 2019. Our CVAT teams, which are law enforcement ride-along teams, mobile crisis management teams, also a grant funded project, which has behavioral health, housing, and substance experts. Our JOT teams are just outreach teams for folks who are criminal justice involved. And then our CAT teams, which is the newest iteration. And these are teams that work with AMR and EMS. One thing I think I'll say there is that recognizing how useful and important these teams are for the community. We went into COVID with 15 of those teams. We're looking to come out of them with 42 of those crisis teams of various types that I mentioned. This is my favorite slide of the deck. These are primarily our CVAT teams, our law enforcement ride-along teams. It's a behavioral health clinician who is paired with a police officer or sheriff's deputies. We have found that these teams to be exceedingly helpful in our efforts in the communities as we move forward. Oh, apparently part of my slide didn't make it, but this is our full service partnership information. And full service partnerships, as you all know, are our most intensive, aggressive outpatient services we provide. And there's, so RAND looked at LA County's FSP programs, and they're very effective at keeping people out of hospitals, off the street, out of jails, Lincoln Barrett primary care. And you look at our own data, it closely mimics that. And so what we've done really over the last couple of years is, we call it building more of the airplane out of the black box material. We've doubled or tripled down on our FSP programs. It used to be too hard to get in, too easy to get out. We've changed the inclusion and exclusion criteria. It used to be that you had to be hospitalized twice in the calendar year or have 2 IMD placements. We made it now that if you hit a psych ER, you can qualify for an FSP slot. And with those changes and some other pieces that we've been working on, we've actually had thousands of folks to our FSP roles. One thing I'll point out, the deltas in the graphs, the deltas in the lower graph are smaller than the top graph, but that's actually a positive in that we are catching folks earlier in their illness. So as opposed to letting folks fail over and over again, decompensate, end up homeless, end up in the hospital, end up in jail, we're trying to intervene and work with folks early in the process so we get them into the right level of care. And that's an important piece of work for us. And I apologize, this slide didn't come out either, but these are our forensic FSP programs. And to get into our forensic FSP programs, you come out of jail, prison, or AB 109. Two things, very positive data in the same areas. And the point I want to make to this group is that really the significant decrease in arrests. The bad joke I've made, and I'll make it again, is that it's not as if these folks are similarly magically getting better at dodging law enforcement. But lo and behold, when you wrap appropriate service around folks and put them in appropriate housing and placements, they do much, much better. So from a public safety issue, this is part of the work that we're trying to do as we move forward, as we build out our FSP teams. And then a lot of my stuff didn't come through, but that's okay. So this is, we're at the end. This is our recovery village. And so the vision of Recovery Village, and I should probably start with what is a recovery village? At its core, a recovery village is a campus. It is a campus that has a full array of behavioral health services, substance use disorder services, physical health services, as well as the full gamut of housing and placement options. But interwoven into all of that is the ethos of social determinants of health. As we've gone through COVID together, we learned a lot from our friends at Public Health. Part of it has been about social determinants of health, the Healthy Places Index. We learned things that your zip code matters more than your genetic code. Seemingly disparate things as tree canopy, green space, and supermarket access have an outsized impact on your quality of life and healthy lifespan. And so for us, our focus on these recovery villages is taking all that we've learned, our focus on full service partnership programs, our focus is on behavioral health integration for physical health care, our focus on community engagement, but layering that educational training, vocational training, which is newer area of focus for us. And what I want to say is that with the work on the FSP programs, with the work on the crisis teams and the urgent cares, gone better, keeping people off the street, out of jail, out of the hospital. But when you think about Maslow's hierarchy of needs, that's really focusing on the lowest two levels, so safety and physiological needs. The hope with this recovery villages is that we're moving our consumers much up towards the peak, towards self-actualization. And then, so this is just an outline of one of the recovery villages that we're looking to build. So again, all the behavioral health, substance use disorder, physical health care, housing options. On top of that, things such as community parks, respite areas, sensory gardens, fitness patios, all ability playgrounds and sports courts. So, I think there's a longer conversation. We'd show you our past, the regular traditional outpatient clinic, simply the psychiatric hospital, more of our future, building out the continuums of care, focused on being in the field, on the streets, the mobile services, and then more of our future, taking all those learnings and really combining it into our efforts in these recovery villages. And with that, I think that's all I really wanted to share. Again, I want to thank you for having me and welcome to Riverside County. Thanks so much.
Thank you, Dr. Chang. I do want to ask if there are any questions or comments from my fellow commissioners at this time.
I'd like to just commend you on what you've created with those, what we saw, the wellness villages, or I apologize if I'm saying it incorrectly, but they
It's
look,
okay, it was on the slide, so you're totally fine.
oh, well, what it was on looked beautiful and welcoming, and it just seemed like everything was accessible in an area and really thoughtfully, created, because the rooms and everything that you guys had pictured was just a place I think anybody would want to like just seek support and help.
I appreciate it. I think it's really been a big effort of the team. Again, I think I've taken up more of your time than I meant to already, but a lot of this is an iterative approach with our crisis teams, and then taking all that we've learned on housing, on placements, and trying to build that into the fabric of the recovery villages.
It was beautiful.
Thank you.
Yeah. I also would like to comment. I appreciate what you said and really focusing on social determinants of health. And we are working on the PEI report, and that's something that we spent a lot of time looking at. And it's not just about one thing, it's about looking at it holistically. And so I appreciate that you said that. I also appreciated the words that you really are addressing, looking at the whole system. And it was too hard to get in and too easy to get out. And if we could just look at that across all of our systems, because they are made that way. And that's where we see system failure. So the fact that you address that, thank you for saying that. And thank you for building your systems around that to make sure that that's not happening. So I appreciated that. So thank you for taking the time. Thank you for welcoming us to Riverside County. We're happy to be here and appreciated your presentation. If there's anything else, then again, thank you
Thanks
for
so
being
I have
much.
here.
a quick question.
Appreciate it.
Oh, sorry. I'm
Okay.
sorry.
I'm
What-
just curious because it's beautiful. What, unless I missed it, how many people does that village serve?
So there are, it depends on the types of village. Our hope is to build 5 of these spread throughout the county. The current ones we're looking at are between 400 to 500 beds. And this gets into a conversation with our PIT count, our point in time count, the fraction of those folks who are homeless by virtue of behavioral health issues and those who are not. And I'm sorry, I don't mean to ramble, but our focus on No Place Like Home, that level of care, the level of care that I'll be providing those villages, and trying to model out and project a bit the type of beds that we'll need. But to answer your question directly, about 400 to 500 beds in a village,
In one village?
in one village.
That's impressive.
Thank you.
Thank you, Dr. Chang. At this time, we will take roll and establish a quorum. Mariani, can you please take roll?
Madam Chair, I'll take care of that responsibility for today. Commissioner Bontrager. Commissioner Boyd. Commissioner Sheriff Brown. Here. Commissioner Bunch. Commissioner Carnavale.
Here.
Commissioner and Assemblymember Carrillo. Commissioner Chambers.
Present.
Commissioner Chen. Commissioner and Senator Cortese. Commissioner Danovich.
Here.
Commissioner Gordon. Commissioner Mitchell.
Here.
Commissioner Rolette.
Here.
Commissioner Tamplin.
Here.
Vice Chair Alvarez. Chair Madrigal Weiss.
Here,
Madam Chair, you have a quorum.
thank you. With that, we are now moving on to agenda item number 2, announcements and committee updates. But first, I would like to invite Commissioners Bunch and Commissioner Brown to say a few words regarding the recent tragedies and the commission's work in the area of our work on firearm violence. Commissioner Bunch.
Commission, California, and the nation are grieving the recent as I was driving here, I distinctly.
Commissioner Bunch, excuse me, we can't hear you.
Can you hear me now?
Probably not.
Are you able to hear me now? Can you hear me now?
Yes, thank you.
As I was driving down here, I was distinctly remembering Chair Madrigal Weiss making a statement after the Uvalde shooting that we are over thoughts and prayers and it's time for action. And I feel like we're still there. We're still ready for action. And what happened this week made that even more so. This week, we had our second committee meeting on the impact of gun violence, and we had an amazing panel and an amazing presenter. And I think one of the strongest voices for me in that meeting was Jace, who is in high school. And I know me personally, I would like to hear at this point more from our youth about the impact of the shootings that have occurred and the acts of mass violence. I'd also like to hear from our communities of color. I think that we are on a good road with the committee. The OAC is doing amazing work. And I'm just looking forward to what else that we can do to try to bring about some kind of change. And I'm really happy to be working with Sheriff Brown in this.
Thank you, Commissioner Bunch. And I would just add to what she has said, that this vexing problem that we have struggled with for far too long in our nation, in our state, and in our counties is very complex and very difficult to solve. And if it was not so, we would have done something about it by now. The magnitude of the challenge, nevertheless, is not going to prevent us from trying to see what we can do to pursue ways to better address these terrible occurrences that are becoming part of, as mentioned, young people's almost expectations as they grow up. They receive training on how to react to shooters on a school campus, and people in workplaces receive it to know what to do if some outbreak of workplace violence occurs. And it is a tremendous problem, and it's something that is also brings together two challenging issues. One is the concern about persons who are suffering with mental illness being stigmatized and unfairly being branded as being violent as a class or as a group. On the same token, we can't deny the fact that many of the people who are involved in these terrible occurrences have been and do suffer from mental illness and have done for some time. And we have to look at what can we do as a community, as a nation, to address these problems and try to prevent them through the right type of early intervention and the right type of treatment to get people to understand that they do have alternatives and they can get their demons under control in many cases. With your approval, Chair, I'll just move into my other comments here as well. Violence has occurred to a great extent in the very recent past, but in particular here in Riverside County, it has taken a toll. Our nation, it's been said that when a law enforcement officer is killed, it's not an agency that loses an officer, it's our entire nation. And recently, the Riverside County Sheriff's Department lost two incredible peace officers, Deputy Sheriffs Isaiah Cordero and Deputy Sheriff Darnell Calhoun. Deputy Isaiah Cordero was 32 years old and had served the sheriff's office for 8 years. He was assigned to a motor unit in the Jurupa Valley. And when he approached a vehicle that he had stopped, a suspect pulled a gun out and opened fire on him immediately, fatally wounding him. A citizen who witnessed the shooting called 911 and rendered aid until other deputies arrived. Deputy Cordero's killer fled the scene and led officers on a vehicle pursuit through multiple counties. And after disabling the suspect's vehicle, pursuing officers shot and killed the suspect after he opened fire on them. The suspect had an extensive criminal history, and he had been convicted of stabbing a California Highway Patrol canine in 2021. And at the time of his murder, of Deputy Cordero's murder, the suspect was out on bail, even after having been arrested for a third strike crime and failing to appear while awaiting a mandatory 25-year to life sentence for stabbing that canine. Deputy Cordero is survived by his parents and his stepbrother. He was known to be a jokester around the station, but he immensely enjoyed serving and helping others in Riverside County. He had achieved his dream when he was assigned to the motor unit in September, a significant accomplishment in what was already developing into a distinguished law enforcement career. Deputy Darnell Calhoun, who was 30 years old, had served the Riverside County Sheriff's Office for 11 months and had previously served with the San Diego Police Department for 2 years. On January 13th, just 15 days after Deputy Cordero's murder, Deputy Calhoun was dispatched to a domestic violence call in the Lake Elsinore community. He was the first to arrive, and when he did, he was immediately shot and wounded. A second deputy arrived and engaged the suspect in a shootout. He was able to wound and disarm the suspect. Deputies then found Deputy Calhoun severely wounded in the street. They loaded him into the back of a patrol vehicle and rushed him to Valley Medical Center, where he died of his wounds. Deputy Calhoun is survived by his pregnant wife and 2 sons. He exemplified what the Riverside County Sheriff's Department want their deputies to be. He was strong, kind, and compassionate. The sacrifice of deputies Isaiah Cordero and Darnell Calhoun reminds us of the dangers that our law enforcement officers face and the potential ultimate price that they are willing to pay to keep our families and our communities safe. May God bless their memory, and may we continue to keep their families and the Riverside Sheriff's Office in our thoughts and prayers.
Thank you, Commissioner Brown, Commissioner Bunch. We extend our condolences and our hearts go out to their families of the 2 officers, and we do thank them for their service. I want to share a couple of announcements at this time. The November meeting recording for November 2022 commission meeting recording is now available on our website. the February commission meeting. The next commission meeting will take place on February 23rd, 2023 in Sacramento as a hybrid meeting. Next, I'm excited to welcome, I don't sound excited, I'm sorry. So I am, let me compose. Okay. I'm excited, I really am excited to welcome two new staff to the commission. Trini Flags has been hired as a retired annuitant in the human resources area. Trini retired from the Department of Rehabilitation in the summer of 2022 after 25 years of doing human resources work for the state. Trini will be performing classification and pay functions for the commission. I would also like to welcome Antonio Andres, who has been a student assistant at the commission since 2021. Antonio has been hired on permanently as an AGPA in the administrative services area and will be providing the commission support, including meeting and IT support. Trini and Antonio are not here with us today, and we look forward to meeting them in person at the next commission meeting in Sacramento. I also want to share very sad news that Ashley Mills, who led the commission's work on criminal justice and suicide prevention, has supported our team working on prevention and early intervention and firearms violence, has taken a leadership position at the California Department of Public Health. We will work to have Ashley join us at a future commission meeting so that we can give her an appropriate thank you for all her contributions to our work and to the California's mental health system. We're sad to see Ashley leave our team and thrilled that such a talented person will be supporting public health across the state. A draft of the commission's report on workplace mental health has been distributed or was distributed in December. The subcommittee met on January 12th, 2023, and voted to send the report to the full commission for consideration of adoption. We hope to bring that report to you for the vote next month. If you have any questions or comments on that report, please share them with staff. We are still seeking applications for the clinician fellowship position. Please review the job posting on our website at www.mhsoac.ca.gov for more information. And we are currently reviewing applications for the peer fellowship. Commissioner Tamplin is supporting that work, and we thank you very much for your leadership on this. And I wanted to let everyone know that the commission approved an additional $1 million of innovation spending authority for Sacramento County's Behavioral Health Crisis Collaborative Innovation Project, originally approved by the commission on May 24th, 2018. Lester, could you please share the slide reflecting that approval? Also, the documents are included in your packets and can also be found on our website under materials. Thank you, Lester. Regarding committee appointments. So normally in January, the commission chair appoints commissioners to lead each of the committees, and the committee chairs then appoints committee members. However, at this time, I'm not making appointments, and I hope to make those announcements instead in February. Later in this meeting, we will talk about priorities for the year, and I want to make sure that our work with the committees is fully supported with our staff resources and aligned with the commission's priorities for the year. Okay, with that was a lot of announcements. I want to welcome everyone again to today's meeting. Recognizing that hybrid meetings can be challenging, we will end at 5 because we will pick this up again tomorrow, and that will go from 9 to approximately 3 o'clock. Commissioners, if you leave the online meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can bring you back into the meeting without needing to unmute. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for agenda item number 3, general public comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue. So please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. Chair, I hand it back to you.
Thank you, Mariani. Would you please open the line for general public comment?
Okay, first we have Richard. Your line is open. You may go ahead.
Hello, this is Richard Geller from Santa Cruz, California. I'm a person with lived experience. I wanted to let the commission know that I have sent a few emails, but have not received anything back, no response. So I don't know whether the commissioners and the leadership staff is receiving it or not, but I want you to be aware of that. Thank you.
Thank you, Richard.
Next, we have Stacy. Your line is open. You may go ahead.
Good afternoon, commissioners, and thank you, Chair Madrigal-Weiss. I wish I could have wished the commission a happy new year without qualifications. But as you all know, what happened a few days ago in the Asian American community prevents me from doing this. 2 mass shootings involving the Asian American Pacific Islander communities in our state were so shocking. Yet before we had time to process this, another mass shooting took place in Oakland. The national news has made it known that in our country, there were more than 1 mass shooting per day so far this year. All of these are making us numb. But I do want to focus on the events of the AAPI communities and how we are trying to cope with this in the aftermath. I believe that most analyses mention that our communities were already suffering from the trauma of increased violence and acts of hate in the wake of COVID pandemic. Research from the Center for the Study of Hate and Extremism found that anti-Asian hate crimes rose by 339% in 2021, while police in San Francisco reported that a 567% increase in anti-Asian hate crimes that year. 45% of Asian American adults say they have experienced at least one of 5 specific offensive incidents since the start of the COVID pandemic. But I do want to remind the commission that you were given the opportunity to directly address the mental health of our youth from the AAPI communities. In 2021, the commission received approximately $5 million from the state budget for a special project. These funds were sponsored by the Asian Pacific Legislative Caucus. According to their website, these funds were to specifically earmark a special peer social network for AAPI youth to connect with and support each other through the use of social media. I hope the commission will ensure that these funds are being used as they were intended by the Asian Pacific Islander Legislative Caucus, and that youth from the AAPI communities will be the focus of this campaign that was set to launch early this year. After the recent events of this week, the need is even more desperate for our youth from our communities. Thank you.
Thank you, Stacy.
That was our final public comment.
Okay, I just wanted to loop back to Richard. So we did just a quick follow-up. Your emails are not being received, so I would ask that you please use the main commission website that is on the website so that we ensure that we get those emails. Thank you, Richard. And thank you, Amariani. And so thank you both for your comments. We are going to move on to agenda item number 4 and consider approval of minutes from the November 17th, 2022 commission meeting. At this time, I would like to invite commissioners to offer comments or questions. I see no questions or comments, none online either. So now it is time then that members of the public make requests to make a public comment on agenda item number 4 by clicking the raise hand button on your computer or app, or if calling in by phone, pushing *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Mariani, are there any public comments?
I see none for the minutes.
All right, thank you. I would now ask for a motion to approve then the November 17th, 2022 meeting minutes. Thank you, Commissioner Danovich. Do I have a second? Second. Thank you, Commissioner Rolette. Any additional questions or comments? Seeing none. Jeff, I would ask if you could please take roll.
Commissioner Bontrager, Commissioner Boyd, Commissioner Brown,
Abstain.
Commissioner Bunch,
Approved.
Commissioner Carnavale. Aye. Commissioner Carrillo. Commissioner Chambers. Commissioner Chen. Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Commissioner Mitchell. Commissioner Rolette. Commissioner Tamplin.
Aye.
Vice Chair Alvarez. Chair Madrigal Weiss.
Aye, and if I could ask you to give Commissioner Chen another opportunity to unmute.
Absolutely. Commissioner Chen.
Let's move on.
The motion passes.
Thank you, Jeff. We will now move on to agenda item number 5, the items calendared for consent. This includes approval of innovation projects from 8 counties. Commission staff have sent the documents related to these projects to all commissioners at the time the January agenda was posted, and a copy of the staff summaries have been provided in your packet. Just a quick reminder that any commissioner can ask to have an item on the consent calendar removed and considered as a regularly scheduled agenda item. For this consent item, the commission will consider approval of Imperial, Kings, Mono, Placer, San Benito, San Joaquin, Siskiyou, and Ventura counties that are seeking approval to use innovation funds to join with 15 existing counties and partner with the California Mental Health Services Authority, CalMesa, on the semi-statewide Enterprise Health Record Innovation Project. The total amount of the innovation funding for these new counties is approximately $30 million. And the 3 key aims for the project are reducing the documentation burden by 30%, increasing the amount of time an already scarce workforce can devote to providing treatment services, facilitating cross-county learning by standardizing data collection and outcome comparisons so that best practices can be scaled quickly, and forming a greater economy of scale so that counties can test and adopt innovation practices with reduced administrative burdens. At this time, I would like to invite commissioners to offer comments or ask any questions. Seeing none and seeing none online, I would ask then that we open up for members of the public to make comments or question. I'm sorry, now is the time for members of the public to request public comments on agenda item number 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now so that the queue will be closing. Mariani, please open the line for public comment on agenda item number 5.
I see no public comments.
Hey. As there are no public comments, I would ask if any other questions. There were no comments. So do we have a motion?
Motion approved.
And do we have a second motion? Thank you. Yeah, please take roll.
Who made the motion and seconded?
Oh, sorry.
Commissioner.
Yes,
May I
please.
help? Madam Chair, Commissioner Brown made the motion and it was seconded by Commissioner Carnavale. Commissioner Bontrager, Commissioner Boyd, Commissioner Brown.
Aye.
Commissioner Bunch,
Aye.
Commissioner Carnavale.
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen. Commissioner, Commissioner Chen. Oh, okay, thank you.
Aye.
Commissioner Chen, aye. There we go. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon. Commissioner Mitchell.
Aye.
Commissioner Rolette. Commissioner Tamplin.
Aye.
Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
The motion passes.
Thank you, Jeff. Next, we will move on to agenda item number 6, the full service partnership report. The commission will receive a presentation and will consider adoption of the full service partnership report as required under Welfare and Institutions Code Section 5845.8 or SB 465. The report is in the commission packet and can also be found on the commission's website at www.mhsoac.ca.gov. We will now hear from Melissa Martin-Mullard, Chief of the Research and Evaluation Division. Please go ahead, Melissa.
Thank you, Madam Chair Madrigal Weiss. Thank you to the commission for this opportunity to share the initial report to the legislature on full service partnerships. The full report is in the meeting packet, but I'm going to today walk through some key aspects of the report, highlight our recommended next steps, and answer any questions you may have. Before I begin, I would like to acknowledge Commissioner Rolette and thank him for his assistance and guidance on developing this initial report. Through his work as CEO of Turning Point Community Programs, which runs numerous FSP programs, we enlisted his help to make sure that we are on the right track as we developed this initial paper. So first, to orient you to the report, I'm going to provide some background and context. In October 2021, Governor Newsom signed Senate Bill 465, which directs the commission to provide biennial reports on the operations of full service partnerships, which I'll also refer to as FSPs, and recommendations on fortifying both the local and statewide response to the needs of Californians who can benefit from these programs. The legislation specifically states that the commission's report shall include 1, information regarding individuals eligible for FSPs, including information on incarceration or criminal justice involvement, housing status or homelessness, hospitalization, and emergency department and crisis service utilization. 2, an assessment of whether individuals most in need of a full service partnership are accessing and participating in them or similar programs. 3, an analysis of outcomes in the 12 months following discharge from an FSP. And 4, identification of barriers for completing report requirements, including identifying data issues. More recently, in September 2022, the governor signed the Community Assistance, Recovery, and Empowerment Act, also known as the CARE Act. This legislation is designed to meet the needs of this same population FSPs are designed to serve. Those individuals who are currently homeless or at risk of homelessness, have prior criminal justice involvement, and a history of hospitalization. Because there's this overlap, it is anticipated that there will be an increased demand for FSP services. Thus, in response to Senate Bill 465 and the likelihood that the CARE Act will increase the need for effective FSP services, the Commission's goals are to improve understanding of how FSPs operate, how they can best serve mental health consumers, and highlight strategies to reduce unnecessary participation in the CARE Act process. Next, I want to provide a brief history of full service partnerships and highlight their critical role along the treatment continuum. In the 1990s, there were coordinated advocacy efforts in California to reduce the number of people who were sent to locked state mental hospitals. 4 pilot projects were funded to test whether comprehensive integrated care for individuals at risk for homelessness, justice involvement, and hospitalization could keep them out of hospitals, serve them effectively in the community at a lower cost to the system. The community program, initially called The Village, was one of those demonstration projects, and some of you may recall a site visit the Commission did several years ago. Initial findings of these programs were promising. They showed reductions in hospitalization, reductions in justice involvement, and reduced number of days unhoused. And the Village was also able to support employment for clients. When the Mental Health Services Act was crafted, full service partnerships were a key investment of the Act. There was alignment in the philosophies of the Act and in full service partnerships. They both have an emphasis on a recovery focus with client voice and choice at the core of the partnership. FSP programs were seen as so critical that MHSA regulations require counties to dedicate a majority of MHSA community services and support funding to FSPs. In addition, counties may use prevention and early intervention funds to support children and youth who may need FSP services. Nearly 20 years after the passage of the MHSA, there have been several statewide and numerous local efforts to measure the impact of full service partnership. Dr. Chang in his introductory remarks talked about one of these local evaluations where the results were promising, and other local and statewide evaluations have shown similar results. Some of these include improved housing, less criminal justice involvement, improved access to services, fewer emergency department visits, a decline in emergency mental health services for children, and overall cost savings to the system. These evaluations help quantify the promise of full service partnerships to be a bulwark against the most devastating impacts of untreated mental illness. As part of the mandates of SB 465, the Commission conducted an initial review of data and information relating to FSPs and identified 3 primary concerns. First, the state faces data quality challenges that impede its capacity to fully understand how effective FSPs are in preventing homelessness, justice involvement, and hospitalization. 2, despite regulatory requirements, county behavioral health departments do not appear to be allocating mandatory minimum funding levels to support FSP programs. And third, California has not established sufficient technical assistance and support to ensure that FSP programs are meeting the goals of reducing homelessness, hospitalization, and justice involvement. Further, we know there are significant numbers of Californians with mental health challenges who lack stable housing, are involved in the criminal justice system, and are cycling through state and community hospitals. These realities raise the following questions that guided our initial inquiry for the report. First, we wanted to understand how effective are FSPs as presently designed and operated at reducing homelessness, incarceration, and hospitalization. What we found was, in order to answer this question, as I mentioned, the data needs to be better. An initial analysis of the data revealed gaps in reporting, missing data, and other questions related to the quality of the data. An analysis of FSP effectiveness relies on quality data. The second question that guided our inquiry is what lessons can be learned from exemplary programs to improve the efficacy of the overall FSP initiative. There's an ongoing multi-county innovation project on full service partnerships, looking at strategies to strengthen the design and delivery of FSP programs and capture the outcomes of these services. As part of this project, counties came up with a set of recommendations to improve current data reporting systems, which the commission supports. Third, is California making adequate investments in FSPs? And if not, what strategies should the state explore to improve the alignment of revenues with programmatic needs and intended outcomes? As part of its work under the terms of SB 465, the commission will work with the Department of Healthcare Services and county behavioral health leaders to clarify the fiscal requirements related to FSPs and strengthen utilization of existing resources to support improved FSP outcomes. The last question that guided our inquiry is what strategies should the state explore or pursue to improve prevention and early intervention strategies to reduce reliance on FSP programs where possible? Research on early psychosis intervention indicates that there are clinically beneficial and cost-effective approaches to care delivery that can prevent the escalation of needs. The governor and legislature have supported several initiatives to increase upstream interventions that have the potential to lower demand for high-cost FSP services, particularly the expansion of access to early psychosis interventions. We're going to tomorrow hear more about some of these initiatives. So given these initial findings, we have some work to do before the next report is due for submission in November 2024. Our initial report lays out a process for developing a strategic data reporting and capacity building plan that will include the following. First, we will form an advisory group, which will include FSP providers, state and local agency representatives, consumers, family members, and others. The advisory group will inform the commission's work on FSPs. We will also identify opportunities for capacity building, piggybacking off of current efforts such as the multi-county innovation project on FSPs. Third, we will conduct a landscape analysis to better understand full service partnerships within the continuum of prevention, early intervention, and treatment. The landscape analysis will help identify upstream strategies that should, over time, reduce the number of individuals who need FSP services, and for those who do need services, shorten the length of time cycling through hospitals, the justice system, and the streets. Another important next step is to focus on data quality improvement. This will be done through exploring opportunities to collaborate and partner with DHCS and county partners on existing efforts to improve data systems so that we can collectively document successes and challenges across the state and report out on the statewide impact of full service partnerships. While we are working on data quality improvements, we propose to continue with data linkages and analyses to better understand population level outcomes associated with FSP programs. Finally, the commission will provide recommendations for an investment strategy for FSPs. Right now, there's confusion over expenditure rules and lack of clarity on whether individuals who meet the criteria of FSPs are getting services. The commission will analyze current expenditures, estimate the unmet need in the state, explore recommendations for reforms on expenditure rules and related strategies. Thank you for the opportunity to provide a high-level overview of the report on full service partnerships. At this time, I'd like to first see if Commissioner Rolette has anything he would like to add before moving on to questions from the rest of the commission and the public.
Let me assure that my microphone is on. Thank you very much. Again, I appreciate the opportunity to participate in the development of this report and to provide a few comments. Certainly, I want to acknowledge the work of staff who took on what I think is essentially the most robust part of the Mental Health Services Act community service funding area, and that's full service partnership. So thank you very much. You all, as I appreciated, began a great deal of work and again, tried to condense it in a manner that indeed points us in a direction. I'm going to make probably 3 comments, Chair, and then one comment that anecdotally might sound a bit humorous at first, but it'll lend itself to what I think. And also I'll start with the 3 comments. First, certainly for individuals, people that we're privileged to serve, the notion of being a part of a full service partnership program as identified here certainly should include data that provides you with an understanding of the unique trajectory of their experience. We are unable to consistently obtain that, and the report points to that. And that is a flaw. It's a major flaw. We've known that for years. The report clearly, again, underscores that. It's not new, but it is something that must be resolved. It's a responsibility that we have to the individuals that we're privileged to serve and to those who are funding those services and providing the services. What happens without data is it underscores and reinforces the notion that I am absolutely opposed to. Let me reiterate what I said. Absolutely opposed to that people don't have an identity outside of specialty mental health services. They should. And in fact, the FSPs are designed to help people to appreciate and manage their Medi-Cal benefit and how to use it effectively such that they can flourish in communities outside of full service partnerships. How do I navigate into and out of a full service partnership and use my Medi-Cal in the same way everybody else does when they're using their other managed care plan benefit? And that's what full service partnerships should do. That also requires then there to be a greater emphasis on technology, as the report indicates. I underscore that point of the report. Technology and again, simply stating the inability for individuals that are using this service to take their experience, albeit via technology, and use that information, albeit via an electronic medical record, and then take that information and understand it, helps to, again, from my perspective, if I'm a utilizer of specialty mental health service, change my perspective around being a consumer of specialty mental health services for the totality of my life. If I understand my benefit better, I might use it better, and it facilitates a different role for me. And that's part of the understanding, and that's part of what not having data and what not having a technology that is again accessible to the consumer. What that reinforces, that people who use specialty mental health services, that's who they are, and I'm adamantly opposed to that. The other point is my little bit of humor, my third point, and that's this notion about advisory groups. So when I turned 60, I said, okay, I'm going to be opposed the rest of my life to California planning more advisory groups because I think we just produce a lot of paper. However, in this particular case, I have some suggestions. I think in this case, you want to make sure that the makeup of the advisory group is at least 50% people who are utilizers of those services currently or in the past, people of color from a variety of different communities, because they provide you with the real information about full service partnerships. And then you want individuals in the community who invested in the act to also to inform who are not associated with the provision of services, to also provide you with information about their own experience, because they have a perspective. And then finally, whatever that advisory group comes up with as the ultimate goal, and that should be directed by staff, it should include a role that is congruent with the notion that reinforces that people who episodically need to utilize specialty mental health services, and I recognize I've said this 3 times, can flourish in the community that they want to live in, just like you and I. And that means understanding how to use my Medi-Cal. That's what CalAIM's supposed to do. It's supposed to help us understand how to use Medi-Cal more effectively and efficiently. And if we can get that out of our communities and then help with the drudgery around, I called it drudgery, all the paperwork, there's my bias, and ensuring that we address the workforce challenges, and that we have data that informs services so that we can consistently identify what works in a small county, in a rural county, works in a larger county, works in a community that's condensed. That would change, in my opinion, the experience that people in our state have with full service partnerships. Thank you.
Any other questions?
Please, commissioners.
The comment is great work, great report, echo everything that my fellow commissioner just said. The question is, I may have missed it in the report, may be there, but one of the areas that we've struggled against in the past in trying to understand how to evaluate the impact of FSPs is defining what an FSP is. Is there a plan to characterize FSP themselves so that we can correlate different models of FSP in different areas against or what, different populations and outcomes?
Yes, thank you for that question. It's a little bit embedded in the landscape analysis item. So part of that will be to try to characterize and look at different FSP models, their components, how they operate differently depending on geography or location or target population. Some of this work is being started by the Multi-County Innovation Project. So we want to build off of the existing work that's happened and get to that kind of catalog or description of the different ways in which full service partnerships can work and look.
Great. That's terrific. And then the other piece that's related to that is we often talk appropriately about FSP in terms of the people they serve, but thinking about the people more broadly as a communities, again, understanding the concentration of FSP in a given community, zip code, geography, region, county is also helpful for being able to do some comparative analysis about, between counties that have more FSP versus less or different models of FSP. So great work.
Any other comments, questions?
Can I clarify what Dr. Jennifer just said? I thought the goal is that everyone would have a similar model of FSP regardless of where the community is.
There are some core components and best practices that should be embedded in any FSP program, but I think beyond that, trying to identify what works for different target population, what works to address the needs of different communities is kind of layered on top of the core components and best practices.
Are you also going to look at, in terms of the provision of FSP? I'm thinking of this more as a clinician because I think one of the things that we struggle with is that there are so many people who need FSP, but not enough clinicians to provide the services. So we might have someone who needs FSP and they're on a 5-month wait list. And by the time 5 months is up, we've seen a significant decline in their functioning where we see that circling in and out of other systems.
Mhm.
Is that one of the things that you're going to be able to look at, ways to decrease that or increase the ability to provide the services?
So I think that as the report mentions, one of the concerns about the CARE Act is that it may increase the demand on FSP services. So recognizing that and recognizing that there are workforce shortages and challenges across the state, I think that's where we want to not just focus on FSP programs, but really situate them along the prevention and early intervention continuum to try to hopefully reduce that funnel of need into FSP programs while also strengthening the capacity of those programs to serve individuals. And I think some of the work, again, that the Multi-County Innovation Project is looking at is eligibility criteria, but also discharge criteria to make sure that, as Dr. Chambers was mentioning, being easy to get into and hard to not hard to discharge from, but being engaged in services. So I think the reason we want to form an advisory group is to really get input from clinicians and providers to be able to address all of these aspects and not to have, a narrow focus on data quality issues, for example.
Please. Thank you so much. I want to echo and ditto what Commissioner Rolette shared about the advisory board, having 50% representation of those that have been part of FSPs in the past or currently, and also the composition being, communities of color also. So having that eye and making sure all, as much as our communities are represented, I really want to uplift that. And of course, to Commissioner Danovich's point around standards for FSPs, I think there's a lot that we can learn from other, in what certain counties are doing. And I know there's innovative FSPs like peer FSPs. And of course, I'm going to support that. But really trying to see like how we can uplift our efforts in certified peer support specialists and workforce development and involvement in FSPs, because we know that, the research shows connection with a peer supporter really helps improve engagement in the services, but also hope and, recovery and wellness. So those are just some things that I know are also part of the goals for FSPs, but really elevating that in this as we move forward.
I appreciate that.
Thank you, Commissioner Templin. I just want to make a couple comments. Commissioner Rolette, thank you so much for the work that you did along with staff. And it's not humorous. I think your points are right on. I agree with what Commissioner Templin is saying. It is important that we do get the voice from those who utilize the services, because it is those who don't that give great opinions, and we know what we can all say about opinions. And so it is those that are really in it that should be advising about it. They know best. And everything that Commissioner Rolette said, that the data is critically important. And when we don't have a system that provides us the data, I'm seeing this across other projects, it's exactly the same problem. We don't have the data. We're not defining things in any coherent way so that we can begin to gather necessary information. And the technology, that is exactly right. The fact that I'm not going to go back to the 60s and say we can get somebody on the moon and we can't have medical records that are, electronic, but we can do so much better. And we have the resource to do so. We just need to have the will. And I think the people have the will. I think the people in this room have the will, and yet we have to push the system to do so. So I appreciate those comments. Thank you so much for all the work done on this. I see it aligned with other projects that we're working on, which really lets me know that we are heading in that right direction, because it's not just the FSPs, but it's other projects that we're working on. There's really, we're having the same kind of findings. And so I know we're in that right direction. So thank you so much, Melissa, for the report update. Thank you. Appreciate it. Yes, please.
I just want to clarify my comment regarding humor was related to advisory groups.
Yes, I got that. I got that absolutely.
Not the composition, not the
No, right.
composition. I completely support making sure that people who not only utilize currently, and I know that there are at times responses to that, but who have been previous utilizers of full service partnership services be included, as well as the community who support funding behavioral health in a way that is impactful and changes the trajectory of the lives of the individuals that we're privileged to serve. And again, this notion about an advisory group, I don't want us to develop an advisory group as an appeasement.
Right.
I want us to develop an advisory group that really does do something of substance and significance in changing how we deliver full service partnership services in California.
Absolutely. Thank you, Commissioner Roulette. All right. At this time, members of the public may request to make a public comment on agenda item number 6 by clicking the raise hand button on your computer or the app, or if by calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Mariani, are there any public comments?
Yes, we currently have 4 public comments. First, we have Richard. Your line is open. You may go ahead.
Hello, this is Richard Geller from Santa Cruz, California. I have not had the opportunity to review this report, but I do strongly believe that the full service partnership is a value program, but it needs to be measured to make sure that the dollars is being well spent and that you are having a higher rate of success for those consumers who are participating in this program. I firmly believe in the commissioner's statement regarding the FSP advisory group to be 50% consumers. I fully support and believe that that is critical to get the feedback from those consumers. Also, I think they need to get paid a stipend for not only as a way of saying thank you, but valuing them as consumers, providing feedback to the Oversight Commission. This is the purpose of the Oversight Commission. Lastly, data needs to be evaluated, not just FSP, but with all programs. You can't connect the dots, see the improvement, then why are we spending money without any measurement? That's not acceptable practice to run. You know, I believe that the commission is working on it. It's trying to build up on it, but we've been waiting for too long since the inception of the Mental Health Services Act. So commissioners and staff, I know you will do your best to improve. It needs to be done. No discussion. Thank you for your support.
Thank you, Richard.
Next, we have Stacy. Your line is open.
Good afternoon, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I really appreciate, I really appreciate that this report was brought before the Commission and the public. I just have a suggestion before the next report. I highly recommend that the report be brought before the Client and Family Leadership Committee and the Cultural and Linguistic Competence Committee, and these committees be allowed to comment formally on the report before it's finalized. They may not have a lot of a lot of comments, but I think this report is extremely important, and I think it's great that the OAC is doing this. So again, that's a process suggestion. Because again, having only 10 days to review this, it's a little bit hard. I admit I should have looked at this more carefully. But in general, I believe that the report should focus a little bit more on the reduction of disparities. And if that is not what's being asked when the FSP program is being analyzed, then it should be. And I believe the Commission could offer that. in general, well, more of the MHSA funds are spent on this FSP, the CSS component than any other. Yet from the start, I've heard from my colleagues on the ground that racial and ethnic communities are not benefiting as much as they could from FSPs. I have heard that they are underrepresented in the FSP programs. And if you note on the page 17 of this report, it says that more than 1/3 of persons, they do not have information on race, ethnicity, or gender identity, or maybe even gender. So again, it's notable and it's commendable that you note that, but where are the recommendations for focusing on that? Lastly, I support Commissioner Rolette's recommendations as others. And I do, in the description in the report, it says consumers, family members, and of course, I support that, and having the advisory body be more than 50%. But I also believe the others should specify, including representatives of racial and ethnic and LGBTQ communities. One of the reasons is because they're underrepresented. So if you're going to get family members and consumers, you also need to get people who can tell you why they're not getting served by these FSPs, not just the people in the services, but the people from the communities.
Please wrap up.
Thank you. From the people from the communities that are not being served. So thank you very much.
Thank you, Stacy.
Okay, next. Oh, 1 second. Next, we have the phone number ending in 718. Your line is open.
Hello, everyone. This is Steve Leone, consumer and advocate. And my first reaction is actually, I'm very pleased with this report. It's a long neglected program model, mostly neglected. It needs a lot of help. And I'm glad that we're finally doing something. I like the general thrust of the report and its thoughtfulness and its openness to have to find out a lot of information yet. And I agree with that. But I want to make a statement, and my standing for what follows, that I'm mentioning this because you may not know any of this, those who have not been around a long time. I'm kind of semi-retired right now, but 25 years ago, I was on the board of directors of one of the main organizations to put through first AB 34 and then the MHSA. And I had conceptual contributions to both. What follows is personal memory plus what I've read. My concern here is I don't want the commission to wind up with egg on its face. You make a mistake in your history section on the origins of the full service partnership. Rather large one. And if anyone else detects it, I don't want the legislature, that's where you're sending this, to say, oh, they don't know what they're talking about. That is not helpful. And basically, it arises from a conflation between the passage of AB 34 in 1999 and the passage of earlier legislation in 1989. And that legislation basically funded the 4 projects referred to, and they were funded by the state. And Mark Reagan's, the most successful by far, was the Village, as you know, in Long Beach. Mark Reagan spent 10 years using outcomes and data and continuous quality improvement to refine the Village. And at the time the AB 34 was passed, the Village was already 10 years old and had gone through 10 years of that development. And I think that's something that should be noted and not left out in passage. It's worth mentioning that he actually started with an ACT model, built from an ACT model. So it's more than simply an ACT model. And after, when AB 34 was passed, Originally, it was only 3 pilot counties, and one of the 4 counties had dropped out. And Sacramento, Solano, and Los Angeles in the form of the Long Beach program. Just similar to the triage grants these days.
Thank you, Steve. Your time is up. You can wrap up your comment.
It was expanded year by year. So please consider delaying this or making factual amendments. Thank you.
Thank you, Steve.
Next, we have Steve McNally. Your line is open. You may go ahead.
Thank you very much. Can you hear me okay?
Yes, we can.
Terrific. I'd like to check. Even though I've been doing Zoom a long time, sometimes you never know. I really like Melissa's presentation of the report. It's well thought out. It's not earth-shattering though. I think it's sort of things we already know or knew. And I agree with Commissioner Rolette. Maybe instead of advisory, maybe we should be an implementation team. I mean, we are in year 17 and we have things legislated that we have to have FSPs and to a lesser degree PACT programs, CERTIF programs in each of the counties. But it's very difficult to know what the linkages are in those programs. And if I just look at page 31 and 32 of the report or the agenda packet, I see that the success rate is 41% and everybody else is in something else. And as our most valued program legislated to be a certain budget amount, it's sort of hard to look at 41%. And when you try to find the details of linkages, because my understanding, it could be wrong, is that they have full referral power for anything in the county. So it's a difficult population, and system users I totally agree with that. We need to get more system users who are actually using it. That's 1/3 of it. The support system that supports that group, hopefully they're not toxic. And the third is the person that is in that FSP program. Do we have the right people as far as they can motivate a difficult population and build enough trust to get them linked to something that move them along? And right now that's very difficult to find. And California's data problem, the open data portal helps a little bit. It's cumbersome. For someone like me, I can get 100,000 lines of Excel and have to clean it up. One suggestion I would have is that you have somebody who knows Excel, since most people who work in these programs will have some kind of working knowledge of data entry for it or higher data entry, and create a system in Excel until we can figure this thing out, because it doesn't take that much to do relative to the impact the information will have. And we're going to wait forever. Well, maybe not forever, but we're going to wait, as you all know, a very long time for California to awaken to a data system.
Thank you,
that's
Steve. Your
helpful.
time is up. Please wrap up your comment.
Thank you, Lester. I appreciate it. I am on a county behavioral health advisory board, but I speak as my own comments. My family has participated in FSPs. They have participated also in PAC programs, and individuals make the biggest difference regardless of what your program is. And I appreciate that. Thank you.
Thank you, Steve.
And then our final comment is Damon, your line is open. You can go ahead.
Hello, everybody. My name is Damon Suja Johnson. They call me Brother Suja. I'm the director at Black Men Speak. I'm also one of the Alamedas County forensic peer specialists here in Oakland. But for this populace, I hope it passed, because I'm a forensic peer specialist here in Oakland. I'm the director, and I'm also a returning family member who spent 35 years in prison. And taking this model, what they have here for the impacted community, as doctors collecting the data, we collect the data here in Alameda County through our PIE report. And so far, yes, it could be improved. You can train practitioners who use it. For small CBOs, we have a whole different address of issues that others don't. Just to get the staff here and train the peers, because I believe the peer movement should be done by peers, even if they happen to be experts, but with that lived experience, to have an understanding, because it's easy to holler these numbers and stuff, but when you're dealing with real people in real time, the data does not reflect the output that peers and forensic peer specialists are having in their community. I've been home just a short time, 3 years to say, and we've impacted a few hundred people using these systems, using our other skills we have to motivate in Alameda County, the 8 dimensions of wellness, to create hope. And as the Commissioner Rowlett said, they keep doing these surveys when the experts aren't, the ones with boots on the ground aren't involved in this process, or when we are involved in this process, and when it's passed down, are we listened to? If we delay, what is happening to the populace in these communities? Because it hasn't been figured out, but I hope you support the passing of this and we can work on it as it goes. Because the people who really need it are the ones aren't worried about data, they need the service. Thank you.
Thank you.
That was our last comment.
Thank you, Mariani. Now that public comment has concluded at this time, I would entertain a motion that the commission adopt the full service partnership report.
I would like to move that the commission adopt the full service partnership report completed by staff. And again, let me reiterate, good work by staff. This is an important beginning. I think that it will ultimately become, and I know I edited myself, it will ultimately become great work. Thank you.
Thank you, Commissioner Rowlett. Do I have a second? Thank you, Commissioner Danovich. Are there any additional questions or comments from commissioners? See no more comments or questions. Jeff, if you could please take the roll.
Commissioner Bontrager, Commissioner Boyd, Commissioner Brown.
Aye.
Commissioner Bunch,
Aye.
Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen,
Aye.
Commissioner Cortese, Commissioner Danovich, Commissioner Gordon, Commissioner Mitchell,
Approved.
Commissioner Rowlett,
Aye.
Commissioner Tamplin,
Aye.
Vice Chair Alvarez, Chair Madrigal Weiss.
Aye.
Motion passes.
Thank you, Jeff. Next, we will move to agenda item number 7, and the commission will consider approval of $7,500,000 in innovation funding for Santa Barbara County's Housing Assistant and Retention Team Program Innovation Project. We will hear from Natalie Rossi, the MHSA Manager for Santa Barbara County Department of Behavioral Wellness. Thank you for being here today. I'm sorry, it is Natalia Rossi. Please go ahead with your presentation.
Hi. We're on.
Just one moment, please.
No problem.
Madam Chair, just because I'm from Santa Barbara County, I'm going to go ahead and step out while this item, and I'll abstain.
Thank you, Commissioner.
I hope you listen in, Sheriff Brown.
Yes.
I'm here.
Perfect.
Do we share our PowerPoint or does the commission? We sent it into you guys before this.
I believe, yeah, we will handle the slides.
Cool. Also, I was somehow made co-host, so I've been admitting people this whole time, maybe.
You know what? We appreciate all the help we can get. So,
but I may not be able to continue with my admitting duties while I'm presenting. Just wanted to.
All right, you're relieved. We're good.
All right, I'm admitting Mike, and then hopefully you guys can figure that out on your end.
I think we are all set.
All right. Hi, everyone. Next slide, please. Just very briefly, I'm Natalia. Hi, I'm our MHSA manager down here in Santa Barbara County. I've worked for the Department of Behavioral Wellness here for about 5 years, but I'm new to my role as MHSA manager. I've been in this position less than a year, 11 months. This is my first time presenting to the Oversight and Accountability Commission. So I'm a little nervous, but excited to be here. Can't see the PowerPoint. There we go. So getting right into it. First slide, a significant portion of our MHSA and No Place Like Home eligible tenants are losing housing and or being evicted despite provision of 20 hours a week of on-site supportive services at our current housing sites. Data from our 21-22 County Housing Community Development Department indicated that 36% of those housed through our coordinated entry system in our continuum of care identified as having a mental health diagnosis. 36% of those that identified as having a mental health diagnosis were out of their housing placement within 6 months. This is our primary problem. After leading focus groups with tenants, clients, and on-site staff at housing sites to identify the root causes, we identified a need for specific support services in the initial phase of housing for those that are newly housed. The problems indicating a need for solution include tenants who need more guidance and assistance on developing and honing their independent living skills. Tenants at times have challenges obtaining basic supplies and accessing transportation. Tenants at times are not engaged in the social benefits programs that they are entitled to. Data on loss of housing after placement is not systematically tracked, and such data could inform our retention strategies. Property management have not had consistent access to training so that they can effectively assist this population. Next slide. Our current supportive housing model only includes part-time on-site case management and limited peer support not available on-site for residents at our MHSA, Home Key, and No Place Like Home funded sites. Our data on housing placement is limited because it's available through our housing management information system. This determines why and how tenants lose their housing, and this data isn't adequate. It doesn't track why people leave housing, and if they've received housing infractions or complaints prior to leaving housing, it just says left housing. The Housing Assistance and Retention Team, that would be our innovations project, it is a three-pronged approach to increase retention within our permanent supportive housing program by assisting clients in the initial phase of their transition to independent living, educating and training housing authority and property management staff and other landlords on how to best serve this unique population, creating data collection methods to drive decision-making and identify emerging needs in this newly housed population. The HEART team would consist of a housing program manager, benefits acquisition trained caseworkers, 2 peer team supervisors, and peer support specialists. The caseworkers and peer support specialists will work with consumers to help them strengthen their independent living skills and connect them to mental health and substance use services. They will assist with the transportation needs, have flex funding available for urgent needs, and will provide intensive peer-led services on a warm line to provide 24-hour-a-day peer support. I would also add that the HEART retention team would be peer-led. Next slide, please. Our stakeholder process for this was long time coming. During the MHSA fiscal year annual update for 22-23, we presented this innovations plan at all 14 stakeholder events we hosted. Comments included the need for more intensive services during the initial phase of housing, and over 90% of respondents on our MHSA update survey either agreed or strongly agreed with this innovations proposal. Additionally, we did focus groups. In early 22, we held 3 focus groups for on-site tenants at 3 housing sites in Lompoc and Santa Maria that are currently funded through either MHSA, Home Key, or No Place Like Home. We had over 35 tenants complete a written survey to establish goals and areas of concern for this project. We then returned to 2 housing sites for in-depth workshops to ensure that this plan aligned with noted areas of concern. For the surveys, we had a survey in 2022 in February to gain opinions on our MHSA, No Place Like Home, and Home Key funded units in the Lompoc and Santa Maria areas, including areas of need and community input. We then had, as I mentioned previously, a section on this proposed innovations plan in our larger MHSA survey for fiscal year 22-23. Over 60 people completed that survey in Spanish and English. Stakeholders suggested making the housing retention team peer-led, increasing available funding for tenant needs, promoting greater transparency regarding why people exit housing, and providing independent living skill coaching. Those things are now part of this plan based on the feedback that we received. Stakeholders also asked for greater training and collaboration with landlords, tenants, and housing management staff. Our department will continue to facilitate stakeholder meetings and tenant surveys every quarter to ensure program success and facilitate data-driven decision-making. Next slide. Goals for this program: we need to better understand our tenants' challenges with housing retention and implement evidence-based programming for reduction of tenant infractions and evictions. Our goals include increasing housing retention for MHSA, Homekey, and No Place Like Home tenants, increasing tenants' ability to secure social service benefits and income, increasing positive resident physical and mental health outcomes, implementing independent living skill building curriculum course for new residents, implementing regular training for property management staff, developing systems to connect data sources for a robust, comprehensive collection and reporting process across all of our housing sites. We plan to implement the homeless information management system universally at all MHSA, No Place Like Home, and Homekey housing sites. Right now, we only use HMIS for tenants that are housed through No Place Like Home. So we would be expanding this. We would use this data system to measure data that is consistent with data being collected at our other housing sites. The epidemiologist for this program would then develop a specific data system to measure reasons for exiting housing sites, why people leave, where they go, and additional factors that we will discover. These data measurements can then be shared countywide to help inform strategies to increase housing retention for those with mental illness across our county, not just those with in our MHSA, No Place Like Home, and Homekey funded sites. We would also then share this information with other behavioral health departments across the state. Next slide. This is our budget in the first year. Be Well will hire one housing program manager, one epidemiologist, and one administrative office personnel. The direct service team in the first year will include 4 caseworkers, 5 peer support specialists, and 1 peer supervisor. In year 2, this direct service team will expand to include 7 caseworkers, 7 peer support specialists, and an additional peer supervisor, so 2 peer supervisors in total. The service team will be peer-led and focus on hiring those with lived experience, particularly those that have experience being unhoused for periods of time. Below is the entire budget. I don't think you need to have me read every number across there. Hopefully you had a chance to review the budget in our plan, also right here in the PowerPoint. Next slide. That reaches the end of the presentation portion of this project. And there's my email. If you guys had additional questions, you can always follow up with me.
Thank you, Natalia. At this time, I would like to invite commissioners to offer any comments or ask any questions.
Sorry, I would like to add that I have our Deputy Chief of Housing Management, Laura Zeitz, on the call with me today, and Nikisa Shojea and Fayan Boutenbrea, who both work with me on MHSA and housing coordination in our county.
Thank you. Welcome. Thank you for being here. Okay. So at this time, we don't have any comments or questions. So what we'd like to do is we're going to go ahead and open it up for members of the public. So at this time, members of the public may request to make a public comment on agenda item number 7 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. And we are going to ask that you please limit your comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item number 7.
We have 2 public comments. The first is Richard. Your line is open.
Hello, this is Richard Geller from Santa Cruz. I just wanted, I could not see the slide on the budget section because of the screen. So what's important for me as a person with lived experience is that your peers will be adequately paid a living wage. It's critical that you have person with lived experience that will stay in the long run and not in the short run. It's about valuing them. So it's critical that you give them the decent pay that they deserve and helping the fellow mental health community. I've done this through the Job Training Partnership Act programs back in the late 80s, connecting individuals to based on what they need, and you are able to measure the outcomes of what their goals were, both short-term and long-term. So it's critical that peers are going to get paid adequately and that the supervisor and the peers are equal as their peers. They're not above anyone else. Thank you.
Thank you, Richard.
Next, we have, sorry if I say this incorrectly, Vertilli Stone. Your line is open.
Good afternoon. I'd like to ask you two questions, if I may. The first one is, can you actually give us a date when the county, the state, either one, is going to really do some housing, get some people in some housing to really get them off the street? Do you have a deadline, a date actually set for that? And my next question would be the care court. I know there's 7 counties right now that's going to be participating in the pilot program. I just wanted to know why Alameda County didn't get a chance to participate, because we have a lot of needs here and we have a lot of homeless people too, and a lot of people in need. Those are my 2 main questions, and I'll go off to hear your answers. Thank you.
Thank you, Veritelli. So the questions are directly speaking to Santa Barbara's presentation on their plan. However, I would ask that you email the general email to our commission and ask those questions specifically. So thank you for being here. So Natalia, or I'm sorry, I'm Mariani. Are there any other questions, general public questions?
No, that was the last comment.
Thank you. So at this time, I would ask if there's any other questions or comments from commissioners. We have, yes, please, Commissioner Roulette.
As I understand the report, and please correct me if I'm mistaken, this is the county's first peer-driven on-site housing support program. And that surprised me to read that. And I was wondering if you could speak to why this is taken, from my perspective, a county that I would assume have already had a program that was peer-led or peer-directed in place. Why it's taken up until now for this?
Well, I don't know if I can speak really to the history of our department, but you may have misunderstood slightly. We do have peer-led programs, but we didn't have any. Our housing support services are limited, right? Right now, it's just 20 hours a week at different housing sites. So we offer peer supports. Sometimes we have peers that visit, but we don't have a peer-led team. These services are offered through our FSPs. So peers are involved. This is different in that the team is peer-led for housing support services. We currently have a peer-led outreach and engagement team, but not for on-site housing supportive services. Do you have an additional question?
No, that clarifies. Again, as I read your document, it says this will be the first peer-driven on-site housing support program, and you don't need me to restate that. And certainly, I'm in endorsement of what you're trying to do. Just was wondering why it hadn't happened sooner, and would have anticipated that it would have happened sooner. And that was just a little surprising to me, and what some of the barriers were maybe, but clearly this is a good project, and so thank you.
Thank you.
Thank you, Commissioner Roulette. Any other questions or comments? Okay, so I appreciate also looking at the report. Couple things. I appreciate the amount of community engagement in shaping this. Really appreciated that. And also what one of our community members said, the livable wages. So really honoring those that you are bringing on, the peers. So congratulations on the great work. Congratulations on really taking the word of the community and engaging them as you shape this. I appreciate that. And thank you for the additional team members that are here, really coming together as a united front. So I appreciate that. Natalia.
Thank you so much. Just one additional comment. We also felt that it was a priority for us to pay beyond living wages. So we actually are paying more than standard wages for the case managers and peer support service positions for this, because we value this program so much and we value their work and want to make sure we can hire people to fill these positions easily.
Yeah, appreciate that. And honoring experience, right? Which is
absolutely
critically important. So thank you for that. I would at this time, okay, all right. So I would ask then that I would entertain a motion that the commission approves the 7,552,000.
Madam Chair,
Oh, yes.
I would like to move.
Thank you. All right, Commissioner
Approve the motion.
Tamplin is going to move to approve the motion for funding Santa Barbara County's Housing Assistance and Retention Team Program Innovation Project. And do we have a second? Thank you, Commissioner Bunch. Are there any additional questions or comments from commissioners? I see none. I would ask then, please, Jeff, if you could take roll.
Commissioner Bontrager, Commissioner Boyd, Commissioner Brown, Commissioner Bunch,
Aye.
Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen,
Aye.
Commissioner Cortese, Commissioner Danovich, Commissioner Gordon, Commissioner Mitchell,
Approved.
Commissioner Rolette,
Aye.
Commissioner Tamplin,
Aye.
Vice Chair Alvarez, Chair Madrigal Weiss.
Aye.
Motion passes.
Thank you. And if I could, I would just like to recognize that Bayanne Wooten is present, daughter of our colleague, late colleague, Commissioner Wooten. So we are happy that you're here. So we're just all waving a hello to you. Thanks for being here and glad that you are now working in Santa Barbara County. I'm sure we'll see you again. So just a shout out. Wanted to say hi. Warm hello from everybody here.
We're very happy to have her.
Hope you see us waving. We can't see ourselves, but here, we're all waving.
Yeah.
Okay, and hearts there. Take good care. All right. Motion passed. Congratulations, Santa Barbara County.
Thank you so much. We look forward to reporting on you, to you guys on this project. Thank
On
you.
you?
On you, to you. Admitting to you. Thank you.
You're very welcome. Take good care.
Thanks.
Okay. All right, moving on to agenda item number 8. The commission will consider approval of 2 Alameda County innovation projects. One is an innovation funding for peer-led continuum for forensics and reentry services, and another funding for alternatives to confinement. We will hear from Roberta Chambers, who is a consultant for the Indigo Project.
Madam Chair, I just wanted to share, because I work for Alameda County Behavioral Health, I will recuse myself and step out of the room.
Thank you, Commissioner Tamplin.
Take my coffee.
We will hear from Roberta Chambers, who is a consultant for the Indigo Project. So thank you for being here today. Roberta, do we have you on?
I think so.
Okay,
Okay, great.
perfect. All right, we see you. There you are.
Wonderful. Well, thank you all for having us. I think we have a number of folks on from Alameda County to support this presentation as well. And when the commission is ready, if we could put up the PowerPoint and kind of share the two innovation projects we have for today. Okay. I think we can go to the next slide. So as was discussed and is in the materials, we are really looking to address address a specific issue that is a problem within the state, nation, and in Alameda County, which is there's a significant need to support people with significant mental health challenges who are involved with the justice system. We know that 25% of Alameda County behavioral health consumers receive services inside the jail, and 10% only receive services inside the jail. Now, this is not a challenge that's unique to Alameda County. However, Alameda County has invested a fair amount of effort into trying to problem solve what this looks like. And we know that despite best efforts to try to help people avoid criminal justice involvement or exit the system, people with mental health challenges are just more likely to become involved. And once they're involved, they're more likely to remain involved and then kind of stay involved. That it's much harder to kind of exit the justice system once involved if you have a mental health issue. I think we can go to the next slide. So we have, as I said, the county has really been working for quite some time to address this. So kind of pre-2020, there was a Justice Involved Mental Health Task Force that worked for over a year and then published a report in September of 2020. This was a task force that had city, county, cross-sector participation, as well as a number of different advocates representing communities from across the county who were invested in finding a way to support people who would become justice involved with mental health issues. So they published in September 2020 a report. The county followed up with a comprehensive mental health and reentry plan the following month, which was informed by just the tremendous work of hundreds of stakeholders who had really kind of put their attention to it. The county then asked us to get involved and really take the ideas in this plan and then kind of have some conversations about what may lend itself to an innovative approach or innovative solution. And so what we did is we did a number of conversations with consumer, family, providers, different communities representative of the diversity of Alameda County, as well as folks from other service sectors. We then kind of took those ideas, put them into concept papers, and then went back out and kind of talked with folks in different conversations, many representing the same communities who had informed the original ideas, and workshop those until we got to the place of here is now a fully baked innovation concept. And that resulted in these two projects. Those innovation plans then were kind of synced up with the MHSA annual update and then went through the community program planning formally as a part of a larger MHSA plan. But the development really is reflective of a few years of work from people who care very deeply about addressing these issues. I think we can go to the next slide. So what we have, and this is a bit of a different presentation in that we need to talk about the problem and whatnot together, which is these two projects are two different approaches to solve the exact same problem. So if the problem itself is reducing criminal justice involvement for people with mental health challenges, there is a clinical model that is a continuum of 3 different programs, and then there's a peer-led continuum that's comprised of 4 different interventions. And so these really are 2 separate sets of services and programs that are intended to see, does any of this, right? These 2 separate approaches, clinician-led and peer-led, really kind of help increase service participation and reduce justice involvement for people with mental health problems. The first one, Alternatives to Confinement, which I'll share more about in a minute, has really looking at kind of a triage or diversion center, a forensic crisis residential program, and then a program to help people comply and complete the terms and conditions of parole or probation. So reducing violations program. And then the peer-led continuum is reentry coaches, RAP for reentry, a forensic peer respite, and then a family navigation and support program. And this is really, these programs are both intended to complement each other, but are very distinct approaches to solving this problem. They also live within a larger comprehensive forensic mental health and reentry plan that really has programs and interventions at every point of the sequential intercept map that task force worked so hard to create. And so just to kind of place that in context. I think we can go to the next slide. So essentially what we're looking at with both programs, and again, they're similar in the problem they're trying to solve, and then they're similar in the outcomes they're trying to achieve, is the outcomes are to increase access and participation in mental health services for people who are involved with the criminal justice system, with the idea that if you can divert people into services and support them as they're exiting, that they're less likely to become or remain involved with the justice system, and then to improve outcomes, specifically reduce justice system involvement for folks who participate. There is a third goal that we are also thinking justice organizations within Alameda County, many of whom participated in the Justice Involved Task Force. Can we go to the next slide? Okay, so thank you. As we look at alternatives to confinement, this is really intended to divert individuals from incarceration in 3 ways. So when someone begins to exhibit early warning signs of behaviors that may lead to police contact, to intervene at that moment, to intervene at the moment of police contact and reduce the likelihood that that person is arrested, and then to intervene when somebody's fallen out of compliance with the terms and conditions of their probation or parole. So to help them come back into compliance with their supervision agreements. This is an arrest diversion triage center, so where law enforcement can take someone to receive mental health services. And triage centers exist in a number of other places. They are generally either placed in a crisis or hospital program or led by justice or physical health providers. This is intended to be a non-crisis mental health led triage center. The forensic crisis residential, would be licensed as a crisis residential. So it has that kind of 5 to 14 day maximum stay, 30 days with CCL, Medi-Cal certification in there, with the idea that this is a place where people can go in lieu of incarceration and in lieu of being confined, basically. It is important to note that the county has received funding from BCHIP for round 3 for the facilities component of the forensic crisis residential. And so there's no innovation funds that are to purchase or renovate or build a facility, if you will, that's been funded by other state funds. And then the third part of it is the reducing parole and probation violations. This is something you see a lot in services to support people experiencing homelessness. You also see it in really in the justice arena, programs that help people who are unlikely to successfully complete community supervision. And so this is providing support so that people can kind of come back into compliance with those supervision agreements without having to go back to jail. And it really is an intervention to coach providers in how to do those negotiations with parole and probation officers. I think we can go to the next slide. So with the budget, again, I mentioned there are some other funds that are supporting the facilities and training of this project. There's also forensic peer specialists that are embedded within the crisis residential program. And so the county received a round 1 BCHIP that will help develop the curriculum and then train the forensic peer specialists. So that's kind of already in motion as well. And then this will give us 18 months of startup to get everything up and going in terms of contract providers and the facilities and whatnot. And then it'll be a full 3.5 years of operations to test this collection of interventions. So even though this is a clinical set of programs, it does integrate forensic peer specialists throughout the staffing model as well. I think we can go to the next slide and talk about the peer-led continuum. So this is kind of the second project, and this is a collection of services that are peer-led to support people to reduce justice involvement and increase service participation. It's intended to help people transition back into the community from incarceration with a reentry coach program. I think we've seen in Orange County and Alameda County and in other counties having kind of mentors or people with lived experience help people transition out of hospital environments is helpful. This is applying that model now into the jail environment specific to people experiencing mental health issues. It's also intending to identify and address issues that led up to arrest so that people can address those issues before they might become have additional contact with the police. That is specific to what the RAP for Reentry program is. I think everybody's familiar with RAP as a program. This is a newer product from the RAP folks. It's really focused on developing the plan that kind of addresses the criminogenic risk and need component. And then we also have a forensic peer respite. So connecting people with the services that they need, including kind of that respite model, but specifically for people who are experiencing justice involvement. This is a place where they may come as they're exiting jail. This is a place they don't have to be exiting jail to participate in the peer respite. But this is, again, it's kind of anywhere from 5 to 30 days, staffed by people with lived experience as forensic peer specialists, with the idea that they would be provided that peer support. And I think some of the RAP for Reentry groups would be provided there as well as in other places to really help people address whatever they need to transition kind of into their recovery journey. The final part of the peer-led continuum is family navigation and support. And this really comes out of the issue that when family members have a loved one who becomes justice involved, that they have to become experts very quickly, both in civil, criminal, procedural codes, and there's kind of a whole new terminology. And so loved ones not only have to become experts in the mental health system, but now they have to become experts in the court process and legal system and penal code and whatnot. And so this develops some materials and provides individual and group consultation directly to family members to really equip them to be the best advocates possible for their loved ones who have become involved with the justice system, with the idea of helping kind of divert them into mental health services and away from the criminal justice system. If we go to the last slide, from a budget perspective, again, this also has an 18-month startup with 3.5 years of full operations. There is some Medi-Cal revenue in this one, a little bit less than in the alternatives to confinement. And this is really to pay for predominantly the staffing associated with this. And again, we do have that good kind of BCHIP funds to develop the forensic peer support curriculum and the certifications. And so that kind of gives us this 5-year budget request. And I think, also the county has already submitted once and is planning to resubmit a BCHIP application for their forensic peer respite. And so there are no facility costs in terms of the peer respite housing itself embedded within the innovation funds. And so I think with that, I think we would be open to questions or about anything we've talked about either of the two projects.
Perfect. Thank you so much, Roberta. We do have questions. We'll begin with Commissioner Bunch, please.
I just wanted to confirm that all of the services are voluntary. I'm thinking of the triage center. If they're dropped off by law enforcement, they then have the opportunity to just leave after they're there.
Yeah, so all of the services are voluntary. And the idea with these projects is really intending to try to create some choice in an environment where there is minimal choice, right? That when somebody is engaging with the justice system, they give up and they lose a lot of the choice that they have. And this is trying to increase that and give them the opportunity. But there is no involuntary services in any of this, and people would be able to leave at any time.
Yes, please. We have a couple more questions.
Dr. Chambers, where would, you mentioned that there's no funding request for facilities, but where would these participants be housed for this 30-day? Where, I mean, do you have a location for the housing component?
Yeah, so one of the county's contracted providers, Telecare, applied for and received a behavioral health community infrastructure program round 3 grant that does all of the renovations on an existing property that they own for the crisis residential program. And so there are costs associated with developing that facility. However, that's already funded through the BCHIP program and kind of in process. For the peer respite, there is an application that will be submitted in one of the future BCHIP funding rounds for the forensic peer respite. And the forensic peer respite, really, that is kind of a residential house. That's the type of environment that would be secured for that. And so those projects those costs will have costs. They're just not a part of the innovation ask because we're trying to put together funds from lots of different places.
And so part 2 of my question is, you know, I love the concept. What have you all included? Is there anything in here for training for, you know, to help families deal with their loved ones, you know, coming out of these programs, or, you know, you mentioned WRAP services. And so we know, you know, wraparound wraps around the entire family. So how do you help shift some of the behavior? And I know we are talking mental, you know, the mental health component, but when we do talk about wraparound, we are talking the entire family. So is there any upstream opportunities to engage with the entire family for, you know, for either program? I'm just curious.
Yeah, so I think there was a lot in that question. So for the peer-led continuum, and this would be available to any family member who had a loved one who become justice involved, there is both individual and group coaching available, recognizing that families do need that support. These programs are not intended to be kind of the entirety of what someone may need or what a family may need. So they're kind of clinically led programs or peer-led and family support as the second project. And then this also lives in a much larger reentry plan that provides a number of other services that help people longer term. These concepts really are to help in those moments where somebody is at risk of being booked into the jail or arrested, and help them kind of get back out into services as opposed to going inside, if that makes sense.
Yeah, I guess. Is there opportunity for the law enforcement contact to also have a shift in thinking in terms of the individuals that they come in contact with, you know, to understand the mental health piece, to understand the criminal logic, you know, the behavior, and then to make these referrals? Because I'm assuming the referrals are going to be coming from, well, tell me, where would the referrals be coming from for these programs, for either one?
Yeah, so some of it can be self-referred or family referred. Some of it can be from law enforcement dropping someone off. And some of it can be from a provider who's working with someone who thinks that they may benefit from the program. So it could come from any of those places, right? And the other part is that as a part of this larger initiative within the county, so Alameda County has a number of programs that exist in partnership with law enforcement and the justice agencies right now, whether it's the kind of myriad mobile crisis, CAP programs, and different ways that that mental health and justice agencies are already working together. We do anticipate that this will give additional opportunity to really help police specifically make the decision to divert into a program instead of arrest. The county's also refreshing their CIT training right now. So there's kind of a lot around this to do exactly, I think, what your questions are suggesting, which is wanting to have that attitudinal change with law enforcement, really support, like there is another option. And, as we were engaging in these conversations with people to develop this, there was some, this idea of wanting to create choice for consumers who are kind of starting to get themselves into trouble, where they have a choice into service as opposed to the justice system. And frankly, law enforcement said something very similar, is that there are minimal choices where they can take folks in those moments of contact, and that it was welcomed to have an idea to have another option for someone.
Thank you.
Yeah.
So my question is, every time I see peer, I just wonder, for this project, the peer-led continuum forensics and reentry services, is the supervisor going to be a peer, or who's actually leading this project?
So for the peer-led continuum, the entirety of the reporting structure is people with lived experience.
Even the supervisors?
Yeah.
I know it sounds like a unique question, but it's happened multiple times where people utilize the word peer. I know Alameda County is really big on making sure peers are in the forefront, but I just wanted to get it on record that the management and as well as the line staff will be peers. Thank you.
Absolutely. I think Alameda County has some great leadership at the within their Office of Consumer Empowerment.
Thank you. Commissioner Brown, please.
Thank you. Yeah, the question I have is for the population that's already incarcerated and coming out. Can you explain your referral process, handoff process? Do you have, I know you have WellPath in the jail up there. Do you, doing the mental health services, do you have discharge planners? Do you have some people that you interact with to get people into this program?
Yeah, do we know if Juan is on the call? Our the director of forensic and reentry services. Stephanie, I know I saw you and
I'm
Kate.
sorry, can you say the name again?
It's Juan Taizon from Alameda County.
I don't think I see them.
All right. Kate, are you able to speak to the discharge process at Santa Rita outside of this program?
If you'd like to speak, you can raise your hand from Alameda County.
Okay.
They left you, Dr. Chambers.
Oh no. So here's what I can say. Let me do my very best. Oh, Stephanie Lewis, let's have Stephanie respond.
Actually, I can't respond to it, but I was going to offer to reach out to Juan. We have an audit going on. Oh, there's Kate too. So they are probably transitioning over right now. Thank you.
Oh, okay. I think I'm on now. Yes?
You are on, Kate.
Okay. Okay. I will do my best to answer your question. What happens is in our system for individuals that are connected to a case management or care coordination team in the community, we have what we call a push report, and that push report goes to that provider to let them know, one, that a person has actually gone into our Santa Rita jail, our local jail. And then two, sometimes someone gets discharged so quickly that even the team, there's no time for that team to get informed. So there is a push report when that person then also gets discharged from the jail. And so that team can quickly then engage that individual as quickly as they possibly can in order to do that. For individuals that are not connected, the staff at the jail that we have there, what they will do is refer an individual to our access unit to get that person connected to one of our teams, whether that's a reentry team, whether that which they can actually do direct referrals to, but sometimes those also come through our access department. And then ideally what happens is if that person is on a longer stay, that they're able to go to the jail to be able to do outreach and engagement. We've been creating codes and opportunities for our teams to be able to do that for a couple of different reasons, reimbursement reasons, and then also so that we can track the kinds of activities that are going on. So that might be a more sort of high level kind of answer to your question, but that's what I can tell you about how things take place.
That's what I'm looking for, and maybe if you can answer this, answer it. If you can't, you can't. But you know, is there a system in place that when someone is being treated for mental illness in the jail, that they are handed off to you, or that in conjunction with other treatment providers in the community, their care continues without interruption or with limited interruption as a result of their discharge? In other words, a warm handoff that they actually, you know, are not faced with the decision of voluntarily going and finding services or a replication of the services that they had, but a continuation of what's been started in the jail if they are indeed doing that.
Yeah, I will answer that happens when we know that, for instance, if they're involved in our adult forensic behavioral health, we have a greater opportunity because they're receiving services from our team that is embedded in the jail. We have a better opportunity to do those warm handoffs, particularly when they are engaged in care coordination, care supports out in the community already. So when they're connected, basically, we have much more opportunities to do those kinds of things. I will say that when individuals are not connected to a team, it is more challenging. And I do know that Juan Taisan has a plan and is currently working to create specifically a discharge planning team to be able to do exactly what you're talking about. And there's Juan, perfect timing. I will hand it off over to Juan.
Good afternoon, all. My apologies. We were in the middle of another meeting around criminal justice, mental health services. My name is Juan Taisan. I am the Director of the Forensic Diversion and Reentry System of Care for Alameda County Behavioral Health. Our system oversees the services in the jail as well as our outpatient services. I believe I caught the question, but please interrupt me and let me know if there are more specifics. I will say in terms of discharge planning, it really occurs. We are moving towards discharge planning occurring at intake. We are now in the jail have moved to a level of care system where we are assessing every individual who comes in, who is booked into the jail, providing them with a specific level of care, housing them appropriately in the jail according to that level of care, and that really drives their services while they're in the jail. The clinician who is meeting with them starts reentry and discharge planning for that client during their more thorough intake process and while they are meeting with them. And then we've built out a discharge team who works with those clients prior to release to make any referrals that the clinician may have identified for that client, whether it be reconnecting to their any service provider that they may have in the community, or making new referrals to service providers who are in the community. And I will say that as we build out this discharge team, it is a learning process as we get our clients more connected to actual treatment in the community. So the goal is and the goal that is being tracked and monitored now is really for our clients to have discharge plans in place, leave with those plans, and be connected to providers in the community. If they are not open to us as adult forensic behavioral health, as Kate was mentioning, they can still request services. So we often get referrals from Alameda County Sheriff's Office for clients individuals who may be leaving, who are not open to us, who are requesting services, and our discharge team will meet with them, will identify those needs, and will refer them to services in the community. The last piece of that is that as individuals are leaving, we have built up a safe landing, what's called a safe landing project at Santa Rita Jail that is staffed by one of our community mental health providers, Roots Community Health Center. They have staff on site. So as individuals are leaving the jail, if they are requesting services and we're not connected to services prior to their release, Roots Community Health Center can quickly assess them, often provides them with immediate needs. So food, it might be a travel voucher so that they can get somewhere, may take them to transport them to services in the community. But then Roots will also do a more thorough assessment and engage that individual to connect them to services via our access center or to one of Roots's programs directly.
And I think to come back to kind of why we're here today, that at any point in that process, safe landing, the discharge planning team, any of those people would be able to refer folks for a reentry coach or for any of the other programs in either of the two innovation projects.
Thank you. Did you have a question? Oh, thank you. We have one more question.
I had a quick comment and a question. I love the idea of a discharge planning team. I do probably 8 to 10 competency evaluations a month, and frequently people are medicated in the jails and then let out on the street with no linkage, no medication, and no services. And I see them again, 6 months later. And they say, I didn't have any medication. So I love that idea. I had a question about the triage center. I'm just trying to kind of wrap my head around the logistics of it because it's such a unique idea. So just if you could walk me through it. Law enforcement has contact with someone on the street. They appear to have a mental health issue, but are not in crisis. And so they would drop them off at the triage center with the idea that they would stay there for the services.
That's correct. And it really is kind of inviting officers to use another opportunity to not have to arrest them, right? Like it's giving them an out. So right now they can take them to a crisis stabilization unit. They can take them to PES. They can arrest them, right? They can take them to a sobering center. But in lieu of that, of addressing that acute, urgent need, they don't have a lot of other options. And so we hear a lot from law enforcement. I don't really want to arrest them. They don't meet criteria to go to the CSU or sobering center, but we cannot leave them here. And so this is really creating a space where they can say, hey, we can take you somewhere else. And then when they get there, there are staff there who are warm, who are welcoming. There's also, you can grab a snack, and then someone can kind of help you figure out what's going on and what your next step is, really just as a way to avoid that arrest when if there's nothing else that they might be able to do.
What's the capacity? How many clients can you have in the triage center?
Yeah, I think we had, because it's it really is just kind of like an outpatient environment. It doesn't have like a bed capacity. I think we have it staffed so there could be like up to like 12, 14 people there at a time if needed.
Thank you.
I just have one quick, I'm sorry, because this is such a unique program, and given what's going on with homelessness, mental illness, this is huge, and the need we all know is there. What about those individuals who are arrested? Because I think Commissioner Bunch asked about folks who were avoiding an arrest and your officer's ability to make a decision to do this. So it almost sounds like they're kind of being trained as quasi social workers, but that's another probably our presentation. But what about that individual who was arrested, to Commissioner Brown's question, and then they're discharged, hopefully not at 4 a.m, but they didn't stay in jail for a long time. So is there an opportunity for that team to be put together to make a referral? Like, what's the expediency of this process? Because some people are, it's probably not a politically correct term, but they're frequent flyers. You know, they kind of use the jails as a place to shelter. So is there an opportunity for these teams to be put together for folks who are arrested? They did commit a crime, they're mentally challenged, and then they're discharged, or, you know, and I don't know what that process looks like, but how soon is that team put together? Because otherwise they're let back out on the street.
Well, the triage center is there all the time. That's not like that somebody just has to get there. I think to Juan's point, there's this existing resource, not a part of the innovation project, which is Safe Landing, which is a place where when you're released from the jail, you can just go there. At that point, you can call the peer respite, you can get assessed for the crisis residential, maybe, right? So that's one way, whether it's the discharge team within the jail that Juan talked about, or Safe Landing, any way to get them connected to one of these programs. We really want to make sure that these services are available. Right now, if someone goes to Safe Landing and they need like a 5 to 30 day residential intervention, whether it's peer-led or clinician-led, there's nothing that's specifically for people who are also involved with the justice system. And so it's really creating that new capacity so that there is a place where somebody can go and work on their mental health and the justice issues at the same time. But I mean, the peer respite, the forensic crisis res, the triage center, those are 24/7 programs.
I'm done. Yeah, thank
So
you.
let me, just for clarification, and we'll go, because we still need to go to public comment, correct? So just for clarification, so we're talking about 2 programs, and I really look forward to learning, Dr. Chambers, for the peer-led continuum, it's for anybody who's in the jail. It's not like you have to have a previous mental health challenge. Is this correct?
So this is for people with mental health issues who are justice involved. It does not require a previous diagnosis. It is intended to be a low barrier and really address the needs that people have. And within the peer-led continuum, the entirety is provided by people with lived experience.
Okay, so then I'd like to make a comment. I appreciated that you looked at data. Your programming development was based on your local data.
Yes.
Love the data piece. Thank you so much. And also that families of individuals who were previously or currently incarcerated were involved in also informing the programming as well. So, and will be a part of the program. So thank you so much for those. I just wanted to add that. So I see no other further questions or comments from fellow commissioners. We are going to move on to public comment. I would ask Amariani that you please open the lines for public comment. And we would ask for public comment if we could limit our comments to 3 minutes, and we will go forward. So Amariani, can you please do that?
Yes, we have 3 public comments. The first is,
If I could just clarify, I think Stephanie Montgomery was part of.
I think there was 2 Stephanies. She might have, unless I'm wrong.
Okay, we'll find out. Okay, go ahead. Sorry.
No worries. Call-in user number 3, your line is open. You can go ahead.
Hi, this is Mark Clements. I have a question for you. Is there a way that there can be a presentation regarding this in Los Angeles? Because I am sure that we need to have programs similar to this in our jails, because we have the largest jail, I think, in the country.
Thank you, Mark. So we do record these meetings. So at best, the recording where they can, anybody that you would want to share that information with or this information with, they can see it on the commission's website. I don't think we can ask for a redo of this information, but they can tap into it on the website. So thank you for your comment. If we can go to the next.
No, my thought is that there should be a presentation, because we've been doing what are called community leadership team meetings. That we had one on Saturday, no, not Saturday, but Friday, then Monday, and again we're going to have one on the 31st, and then one in February 17th.
Thank you, Mark.
And we can get you the materials, I think.
Thank you.
Okay, next we have Stephanie Montgomery. Your line is open.
Hello, thank you. I represent Alameda County Behavioral Health. I'm the Health Equity Division Director and Health Equity Officer. And I just hope that this body move to approve this, because it's community-led and driven, as well as our data that we found. And as we know, emotions are high around what's happening around community violence. And here in Alameda County Behavioral Health, we're in the middle of a very delicate balance of making sure that we honor folks' human rights and individual rights, and also make sure that we keep community safety in mind. And we think that this would be a great balance of both of those things. And there's nothing better than someone to see a peer who's been there, done that, and has made it, than to be a motivating factor, or that perhaps someone else can make it too. So thank you for your time.
Thank you, Stephanie.
Next we have Rashonda. Your line is open.
Hello, hi, my name is Rashonda and I represent Alameda County Behavioral Health, the Office of Peer Support. And I too hope that this passes. There's a huge need for something in between being locked up as the only alternative for someone who is challenged in the moment with mental health crisis. We need to give the person and the officer something else. It's not, right now in Alameda County, that's what they have. And this would be that thing that is needed on both sides. And so I'm pressing upon you to give that thing. This is that thing. This is what we need right now. We need to give a different space for both sides. The officers need something, the people and the family, they need a different thing. And this is that thing that will help everyone. So I press upon you as an Alameda County staff person, but also as a consumer and a family member. I'm asking for this separate thing, this different thing. So thank you.
Thank you, Rashonda.
Next we have Brian. Your line is open. You may go ahead.
Thank you. Thanks, Roberta, for a great presentation. I'm the chairman of the Mental Health Advisory Board in Alameda County, and the board wholeheartedly endorses and supports both of these proposals. We urge this commission to do what it can to forward it, to accept it, and to move it along. My only comment, and for all the reasons that it's been stated by the last couple of speakers, my only comment is this: I urge us not to forget, by us I mean people that care about these issues and think about them. I urge us not to forget that as good as this program is, and it'll help so many people, there are so many people in jail that are too ill, they suffer too severely to avail themselves of voluntary services. And we have to think about other ways to address the folks that are in competent stand trial who languish in jail without treatment for 6, 7, 8, 9 months. And folks like that, obviously another population, but I'm just urging us not to forget those people. I think we have a moral responsibility to help the folks that are the sickest. But notwithstanding those comments, please do what you can to forward these two proposals along. They would make a huge difference in Alameda County. The Mental Health Advisory Board has heard Roberta's presentation before, and we're fully behind it. So thank you.
Thank you, Brian.
That's our last comment I believe we can take for the moment. We have to move on due to time constraints.
Thank you, Mariani. Now that public comment has concluded at this time, I would entertain a motion that the commission approves the innovation funding for peer-led continuum for forensics and reentry services and innovation funding for alternatives to confinement. Thank you. I'm sorry, Commissioner Mitchell has moved. Do I have a second? I'd like to second. Can I? Thank you. I would like to second. Are there any additional questions or comments from commissioners? Seeing none, Jeff, I would ask that you please take roll.
Commissioner Bontrager, Commissioner Boyd, Commissioner Brown. Aye. Commissioner Bunch.
Aye.
Commissioner Carnavale. Aye. Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Commissioner Mitchell.
Approved.
Commissioner Rolette.
Aye.
Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
The motion passes.
Congratulations, Dr. Chambers and Alameda County. We look forward to learning from you. Have a wonderful day. I know you're on mute. We have 10 minutes left. So congratulations. Have a wonderful day. We look forward to it. At this time, okay, we are. Moving on to agenda item number 9, the commission will be presented with the governor's 23-24 proposed budget as it relates to mental health, a mid-year update of the commission's 22-23 expenditures, and consider approving new expenditures. We will hear from Norma Pate, Deputy Director of Administration. Please go ahead, Norma. I'm sorry. I know we're going to put you on a rush.
Oh, no, it's fine. And
You
I'm
can do
gonna skip over the governor's overview of the budget. It's
Okay.
all in the packets. If you guys need more information, it's in tab 9. This is the beginning of a really long process, and we don't have a lot of details on the governor's budget at this point. But over the next few months, we'll start participating in hearings and engage with the legislature and have more information to share. But I'm happy to answer any questions that anyone has. If you want to reach out to me and I can help answer any questions on the governor's budget. And I'll just go directly to the commission's mid-year update budget. And the budget shows what the commission approved in July, which is the approved 22-23 budget. We made some adjustments to the budget. We have about approximately 1 million in salary savings. We received several positions last year. Some of these positions are difficult to fill in the scientific series. The positions are difficult to recruit for those positions, and we're coming up with a recruitment strategy to engage and make sure that we get the right candidates to fill these important positions. So we've modified the budget, and it's shown in the adjustment column. And so we're requesting today to reallocate funds from our salary savings to support communications, IT, and unanticipated costs associated with our new building and AV equipment that we need to support hybrid meetings. And then As you recall, in July, the commission approved 500,000 to continue the national engagement campaign through 2023 and to support a second documentary series, Hiding in Plain Sight, Adult Mental Illness, slated to premiere on PBS in 2025. That's also an adjustment to the original budget. And also, the commission approved an IT infrastructure contract in the amount of 156,000, and that's also listed in the adjustments. I'm going to go ahead and go directly to the next slide, which is today, our ask is for 1.5 million from the Mental Health Student Services Act Evaluation and Administrative Fund to be awarded to West Ed for initial evaluation work of Mental Health Student Services Act grants. The funds will be used to develop an evaluation plan, continue community engagement around key metrics for school mental health, and conduct an analysis of current grantee findings and challenges. We're also asking for 300,000, which will go into more detail tomorrow for our strategic plan for 2024 through 2027. Sorry, that was hard to get out. And then, and also we're also requesting to work with the legislature on a funding request. It was presented to you at the last meeting from the Department of Aging, which is additional funds for the advocacy contracts, 670,000 ongoing funds to support older adults. So today I'm asking for approval for the update to the expenditure plan and the associated contracts, and then the contracts that are listed here in the slide for expenditure authority. And the motion is to for the commission to approve the fiscal year 2022-23 mid-year expenditure plan and associated contracts. And I'm happy to answer any questions you might have.
I'm sorry, can you go back one slide? You said something in between the 300,000 from operations fund for the strategic plan. And then I heard another number before the 110,000 for communications fund about older adults.
The 1.5 million for the Mental Health Student Services Act, and then 300,000 for a strategic plan. And then 110 for the communications Crossing T contract.
And then what did you say about older adults and how much was that?
And then older adults, we received a presentation at our last meeting for advocacy funds for older adults. And so we'll begin to engage with the legislature, if approved, to request funding for older adults.
Oh, okay,
advocacy.
so there was no dollar. Okay, I'm sorry,
Yeah.
my mistake. Okay, fine.
Yeah. Sorry, I was trying to go too fast.
No, I thought I heard a number and I was like, where's the number? So, okay, my mistake.
No. Any questions?
Question.
Please.
Just clarification, the strategic plan, $300,000 for that. Is that for the upcoming strategic plan? It's for beginning period 2020?
Yes, for the 2024 through 2027, yes.
Any other questions? Commissioner Danovich.
Second.
I'm sorry, who said second?
Second.
Thank you, Commissioner Carnavale.
We're not doing public comment?
We still have to do public comments. All right. Are there, this time, members of the public may request to make a public comment on agenda item number 9 by clicking the raise hand button on your computer or the app, or if calling in by phone *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make a request to comment now. And I will ask you to please limit your comments to, I'm going to ask for 1 minute, please. 2 minutes, 2 minutes, apologize, 2 minutes. Amariani, are there any public comments?
We have one. We have Stacy. Your line is open.
Stacy, please go ahead.
Yes, hello, Stacy Hiramoto, REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I'm not asking you to answer this. I know the commissioners are not supposed to answer questions, but I hope at a later date that the commission will make more clear how it is going to spend the 42 or whatever $1 million on the children's, that is part of the Children and Youth Behavioral Health Initiative of the governor. I have had many, many colleagues ask me, because I go to these meetings, what the plan is for that money. And I keep telling them I'm listening and I'm confused and I don't know. So thank you for another time. Thank you. But that is part of your budget.
Thank you, Stacy, and we will address when we add that to the agenda. So we will be clear at that point. Thank you so much, Stacy. Any other comments, Mariani?
No, that was our only public comment.
All right, thank you. So any other comments or questions from fellow commissioners? Okay, seeing no more comments from commissioners, I would ask that Jeff please take the roll.
Commissioner Danovich. Commissioner Bontrager. Commissioner Boyd. Commissioner Brown. Commissioner Bunch.
Aye.
Commissioner Carnavale. Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Gordon. Commissioner Mitchell.
Approved.
Commissioner Rolette.
Aye.
Commissioner Tamplin.
Hi.
Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
Motion passes.
Thank you, Jeff. Thank you, everyone, for joining us today to continue the work and discussions around mental health. We will recess for today. We will reconvene this meeting tomorrow, January 26th at 9 a.m. Thank you and have a very nice evening.